Good morning, my name is Maite Medina. This is Miami Regional University. I'm doing the second presentation for 5041C. And this is a patient, demographics is 91-year-old African-American male. The complaint is behavioral change. History of present illness, 91-year-old African-American male with past medical history of alcoholism, presented with behavioral change. For example, lack of grooming, not recognizing persons he already know, erratic from the past week. Patient has been studied and found to have positive for treponema pallidum in cerebrospinal fluid. Patient admitted in WGRH for continuum of care. Today's scene bedside shall review case discussed with the staff. No event through the night will follow. Revision of system. Constitutional positive for fever, but it's a low-grade fever. Chill, sweat, weight loss, musculoskeletal difficulty with his balance and ambulation, diadochokinesis, neuro positive for headache, balance deficit, social history, alcoholism, but mostly unknown. Patient is poor historian, also the speech is not very sensical. Physical examination, abdomen soft, non-tender, not distended, liver is 4 centimeters below costal margin, spleen also increasing size, palpable, neuro positive thromboid sign, diadochokinesis, Argyll Robinson pupils, which are small pupils that do not contract further but do accommodate. Negative non-nuchal rigidity, no dysarthria, no cranial nerve affected except for the Argyll Robinson pupil, no aphasia. Labs. Serologic test. Non-treponemal BDRL used for screening. Rapid plasma regime also for screening. Treponemal test, FTA apps, immunofluorescent with absorber serum, confirmatory diagnostic, not for routine screening, and also the TPPA mycoagglutination, confirmatory diagnostic, similar to the other one, but can be quantitated and automated. And since immunoassay EIS has become recently available, confirmatory and increasingly used for screening, it is also automated. The definite confirmation is observing the treponema in dark field, which is possible in primary lesions in mucosas of patients of congenital syphilis, aspirate of lymph nodes, or biopsy of pathological specimens. Diagnostics. This patient has neurosyphilis. Differential. Metabolic encephalopathy with it will be more confusion, the patient will look more ill, the liver enzymes will be elevated, there will be coagulation problem, icterus. Also, if the patient has a bowel movement every 2 to 3 days, it might not occur. Bacterial meningitis, acute high fever, nuchal rigidity, cerebrospinal fluid with bacteria, and leucos very high, predominantly polymorphonuclear with bands. And the CVS will be polymorphonuclears and bands. Viral meningitis is less bad, but also with fever, acute fever, nuchal rigidity, acutely sick patient. The cerebrospinal fluid will also be changed. There will be high leucos, and also there will be change in the glucose. The CBC will be positive for lymphocytosis. Metastatic brain tumor, there will be behavioral change, but lifestyle have been different. Usually smoker, chest X-ray, when the lung is the primitive, there will be 11 forms of being manifested in the X-ray, but one of them is that it could be normal. CT of brain, we will observe the tumor. So we rule out all of this because of the physical examination, the clinical picture, and also the labs, and imaginary. Now, about the syphilis. Syphilis is a chronic sexually transmitted disease acquired by sexual contact, almost exclusively. Also from mother to fetus, the congenital syphilis. Before the new modern techniques on blood banks, it could be acquired by blood transfusion, but not nowadays. And occasionally has been seen in patients with Dachshund needles for drug use. It's caused by a Treponema pallidum. It's a spirochete, a bacteria subspecies pallidum. It's small to be seen by ground stain, so it can be seen in wet mount by dark field microscopy or in fixed specimen with silver stain or fluorescence antibody methods. The outer membrane of this bacteria is made out of phospholipids, as different from other bacteria that have proteins in the membrane. This is an advantage for it and is also to account for the way it goes against all the defense of the human body. The host is also only the human body and some apes and some high monkeys. Culture is limited of use limited use in research and useless in clinical setting. All isolators are susceptible to penicillin. The only host is human. There is congenital syphilis, like I said. Aside from the acquired, the primary syphilis usually have a chancre. It's a lesion that goes in the psyche, in the port of entry in the human being. It could be usually in the anal-regional area, but can also be found in nipples, mouth, tongue, pharynx, almost different parts of the body. The natural course of the disease. After the exposure, there is an incubation period that goes from 10 to 90 days, usually 21, and painless papule appear at the site of inoculation. That papule soon breaks down and leaves the clean base ulcer that with rise and indurated margins. It's painless. It is not itchy either. The chancre. It lasts for 2 to 6 weeks and heals spontaneously. Several weeks later, patient has low-grade fever, headache, malaise, generalized lymphadenopathy, and mucocutaneous rash. Some organs may be affected. This eruption may occur while the chancre is still healing or up to several months later. This secondary lesion also heals spontaneously within 2 to 6 weeks, and then it goes latent in more than 20% of patients if untreated, with lesions in eye, skin, central nervous system, hearts, and other organs. Like I said, the chancre is painless, starts as a papule, becomes an ulcer, and is associated with regional adenopathy, uni or bilateral. The regional nodes are movable, discrete, and rubbery. The late syphilis is not contagious. It has 3 forms: benign, also called comatose, cardiovascular, and neurologic. The cardiovascular used to be aortic insufficiency, aortic ascendant aneurysm, and occasionally coronary disease, all by obliterative endarteritis of the vasa vasorum of the great vessels. The gomas are relatively rare in the time of penicillin, but may appear 1 to 10 years later of the initial infection. They respond to treatment with penicillin. Histologically speaking, they are granulomas. Neurosyphilis comprise 5 groups. Asymptomatic syphilis meningitis can happen at any time after infection, but commonly after 5 years. It takes the base of the skull, unilateral or bilateral cranial nails palsy. Mild affecting meningitis may occur in early syphilis, but severe meningitis occurs in 1.5% of untreated patients, typically resolved spontaneously. Meningovascular syphilis occurs 5 to 10 years after, produce cerebrovascular thrombosis, and infarction may be considered a cause in young patients that have cerebrovascular accidents without other risk factors. Tabes dorsalis, progressive degeneration of posterior columns and posterior roots of spinal cord, and cause loss of reflexes and impairment of vibration and position senses, and progressive ataxia. Tabes dorsalis, the sensory loss may lead to deformity and destruction of major joints, also called Charcot joints. Of affected limbs, bladder incontinence and impotence are common. As part of this syndrome are severe sudden crises of intense pain of uncertain origin. The abdominal pain may cause the patient to have exploratory laparotomy. Optic atrophy is apparent in 20% of affected. 90% have pupils small that fail to contract further in response to light, but they do respond normally to accommodation. Ariel Robinson pupils. Epidemiology. Syphilis spares no class, race, or group, but it is more frequent among those living marginally in the society. In the United States, it's six-fold greater in African Americans than in non-white Hispanics, in non-Hispanic whites. In 2012, the 75% of cases were men reporting sex with men. Increased the amount of different partners and indiscriminate choice of partners increased the risk. Patients with primary and secondary name average 3 different partners in last 90 days. There have been waves in increased cases related to social unrest and increased drug use, especially crack cocaine use. Before, it was part of treatment control and treatment of contacts, but with drug use and anonymous sex, this is less efficacious. It is most common in larger cities and in young sexually active, mostly men between 20 and 29 years old. With the discovery of penicillin, it decreased, and then the expenditure of money on the disease was overall diminished by the federal government. So the disease was up again, reaching up to 12 for 100,000 people from 1965 through the 90s, maybe more, since many cases go unreported. During the past 40 years, it has been happening serially in 3 population subgroups. Within 1970 to the 1980s, mostly men who have sex with men. From the 86 to 90, multiracial heterosexual men and women, coincident with the epidemic of crack use. After 1990, it declined. 2001 was the lowest rate since 1959. During 2005 to 2013, syphilis has increased in men of all races and ethnicities, and in women as well. Patients with the cardiovascular form of tertiary are now less seen, perhaps because of the penicillin. However, there are a great number of persons with untreated neurological syphilis, especially in older age group. So this is basically the presentation. The treatment is benzathine penicillin. 1 million units intramuscular weekly for 3 weeks. The patient with allergy to penicillin should have to be desensitized in order to receive the treatment. It's a reportable disease. So this is the presentation. Thank you for watching. You may see the reference.